I'll be talking about selecting the patients for awake spine surgery. So a disclaimer, I do my surgeries under local anesthesia, no spinal epidural business for me. And the usual pathologies one encounter in the practice, can I have a laser pointer please, are disc, cervical, lumbar, thoracic, trauma, infection and fusion. And this will account for 80 to 90% practice of any spine surgeon. So surgery under local anesthesia, where does it work? What is its scope? And as you discuss the patients, you will recognize what patients can we take up for this kind of pathologies. So routine disectomies, stitchless spine surgery under local anesthesia. A routine disectomy, everybody is well aware of these surgeries where we do endoscopic transforaminal under local anesthesia and the patient is awake. We can talk to the patient. For interest of time, I'll be speeding across a lot of the videos. And you can, literally talk to the patient and get the disc out. And here it is, small scars. So can we go to cervical? Another case, PIVD C5, C6 with left paracentral cord compression. You can see on the MRI there. And CTs, no osteophyte, a disc, patient supine, again awake. This is how I fix the patient so they don't move. Now local anesthesia being given, level identified, infiltrated with the local anesthetic. You can see there, now the dilator goes in, disc forceps to do a gross decompression. Finally the endoscope, bipolar forceps up to the PLL, everything can be done under local anesthesia. The advantage is, patient is awake, on the table, they tell us that the radiculopathy is gone. You can see, all this is being done under local anesthesia again. And the fragments are fished out, PLL is seen, everything falls back immediately on the table, patient is pain-free. So can we now go up to fusions? Yes, 14-year-old female, walking distance 30 meters, you can see the listhesis there, suitable case for an indirect decompression. So this is how we do it, prone positioning, dual C-arm, local anesthetic being given. Again, transcambon approach. Dilator inside, then big gross instruments to do a disectomy, hardly takes 2 minutes. We have some special instruments, a cage which as it goes in, the exiting route gets displaced, putting the bone graft, iliac crest, again under local anesthesia, screws under, you can see the patient is awake, and this is under local anesthesia again. You can supplement it with epidural. For your initial cases, now I don't use it anymore. Screws, everything under local anesthesia. You can see patient is well awake and local anesthetic being given when required. This is the final construct. These are the scars. And within half an hour, 40 minutes, you can mobilize the patient. It's a total outpatient surgery. 2-level surgeries, again under local anesthesia. 3-level surgeries, again under local anesthesia. And you can see the decompressions there. Infections, again a pot spine case. You can see the patient has a chest tube. Nobody is going to give general anesthesia to this. Decompression, again with the help of an endoscope under local anesthesia. Fixation, again under local anesthesia. So you can see this. Another case, spondylodiscitis C3, C4, L4, L5. It is already a case of dish, no need for fusion. So here we don't even use an endoscope, put bilateral transcambon cannulas, and you can see here from one port, my assistant is irrigating, from the other I'm doing the suctioning, and then just reversing. So we can thoroughly do the washout, no need for a scope there. For the cervical, just aspirate under local anesthesia. Another case, L3, L4, pseudoarthrosis. So again, you can see fixation. Then streptomycin loaded beads. Stimulant I've used here, again under local anesthesia. Just fill up the space, fixation. Everything under local anesthesia. This has got published as well. Another case, C1, C2. You can see here it is already fused, and patient has and there is a big, syrinx there, and patient has an SpO2 of around 60%. Patient placed in the lateral position, then decompression again with the stenosis scope This is all done under local anesthesia. And you can see the patient is awake, he's moving his hands, and we are doing the decompression. And we can talk to the patient. The anesthetists were not ready to give anesthesia to this. And this is the awake patient, and this is the level of decompression. You can see well decompressed.
Varun will have to wind up, conclude.
So as you can see, whatever contraindications everybody has pointed out for an awake surgery, we can do under a local anesthesia. And even cement augmented screws, everything we are doing under local anesthesia now in my center. And this is our anesthesia protocol. So the take-home message: careful patient selection, thorough knowledge about the procedure, explain procedure well to the patient. So kyphoplasty, cement augmented screws, discectomy, neuro-intact patient but requiring fixation for instability like trauma, degenerative instability, suitable for indirect decompression. All these can be done for an awake patient and even under local anesthesia. So this is our new society. I invite everybody to join this. And thanks a lot for a patient hearing.